There's a call I'll never forget. Right after I got out of medic school in 98, so the call was probably in 99 or 2000, we got toned out from the fire station to a call right down the street. It was a little one-story brick ranch up on a hill. We had to carry all the bags up the hill. It's for a chest pain call, 70-year-old male. We walk into the kitchen. He's sitting there at the kitchen table, and I knew right away what was going on. He had all the classic signs. He was pale, cool, and diaphoretic. He was doing the classic clench sign. There is no doubt in my mind as I walked into his kitchen that he was suffering from an MI. I start to assess the patient, start taking blood pressure, start taking vital signs. I got into my head that this is a pretty classic chest pain call. We're going to do what we need to do, treat him appropriately, get him in the bus, and get him down to the hospital. That's when he looked at me and he said one thing that I'll never forget. He said, "You will not be taking me to the hospital today." And I didn't know what to do. I had never experienced anyone having such a critical medical complaint and them not want to go to the hospital. One of the most greatest liabilities we have is not the cardiac arrest. It's not the multi-vehicle car accident that occurs on the interstate. The call with the greatest liability is your patient refusals. So today, my name is Nick Adams. I'm a division chief with Cobb County Fire and Emergency Services. And today I brought with me an attorney to help us kind of guide through the liabilities of patient refusals.
So I'm Samantha Johnson. I'm a Senior Associate General Counsel with Grady Health System and with Grady EMS. And we're going to talk about why refusals are the most difficult calls, give you some tips and tricks on how to handle them.
So sign here, A Practitioner's Guide to Patient Refusals.
We're going to start off with a couple of disclaimers today. First, the views expressed in this presentation are not necessarily the views of our respective services. We expect that everyone will follow their local protocols and their local medical direction. We don't have any conflicts of interest. We're just doing this for education for you guys. We have de-identified the PHI unless it has been reported in the news media. And of course, although we're giving you hopefully best practices, while I am an attorney, I'm not everybody's attorney, so make sure that you check with your services lawyer as to the contents of this presentation.
All right, we're going to be learning three things today. The first thing, we're going to examine the clinical, legal, ethical, and operational issues associated with patient refusals. Next, we're going to analyze the legal impact of provider-initiated refusals and alternate transport destinations. And then finally, we're going to demonstrate the role of documentation reducing legal liability for patient refusals.
So let's start off with talking about the kind of terms that are going to come up in this presentation. The first being the difference between competency and capacity. So in the U.S., a competent person has a liberty interest under the Due Process Clause in refusing unwanted medical treatment. But the issue of competency versus capacity is one that a lot of folks have trouble with. Competency is a legal term. Only a judge can determine whether somebody is competent or incompetent. So it does come up in cases like readiness for trial for some criminal defendants, or persons under guardianship may be declared incompetent, which means that they do not have the ability to make any medical decisions at all. Capacity is a medical term. It's a more fluid situation. You can have capacity one moment and not in the next. Capacity is generally assessed by physicians in the hospital, but it can also be assessed by EMS personnel in the field. So for example, a patient who is unconscious lacks capacity in that moment, but the person may wake up and regain their capacity. So it is a fluid term that can wax and wane over the course of a call or over the course of a few minutes.
In a stunning turn of events, a superhero is being sued for saving someone who apparently didn't want to be saved. The plaintiff, Oliver Sansweet, who was foiled in his attempted suicide by Mr. Incredible, has filed suit against the famed superhero in Superior Court.
Mr. Sansweet didn't ask to be saved. Mr. Sansweet didn't want to be saved. And the injury received from Mr. Incredible's actions, so-called, causes him daily pain.
Hey, I saved your life!
You didn't save my life, you ruined my death. That's what you did.
Listen,
my client has no
little
further
piece.
comment at this time.
5 days later, another suit was filed by the victims of the L train accident. Incredible's court losses cost the government millions.
Mr. Incredible actually goes to save a guy's life. He thinks he's the hero. Hey, I saved your life. And of course, he sues him. So that's what we're going to be kind of talking about today.
If you transport a patient or provide care against their wishes, you open yourself up to legal liability for a couple of different things. The first being assault, which means that you are attempting to do something to a patient that they don't want you to do. In battery, you actually have done the thing, like, for example, sticking someone with an IV. You can be liable for false imprisonment if you stick someone in the ambulance and tell them they cannot leave. And sometimes intentional infliction of emotional distress, if you intentionally create a situation where you put somebody in fear of their situation, or you're intending to cause them emotional distress. So you want to make sure that your patient has the capacity and is consented to your treatment if they're able to do it.
So going back to my patient, my 70-year-old male, pale, cool diaphoretic, clenched fists. Go ahead and hook him up to the 12-lead EKG, and it's clearly not good. Everything I know, everything that's telling me as a paramedic is that this, again, is a fairly simple case. We can treat him, we can get him down to the cath lab, we can fix his problem, and we can save his life. But he, especially some of our elderly population, was extraordinarily afraid of the hospital because that's the place that all their friends went to die. So he told me, he said, you will not be taking me down to that hospital today and just laying hospital bills on my family for me just to pass away and then be burdened with the hospital bills. So being a fairly new medic, I had absolutely no idea what to do. I started researching and worked with Samantha to come up with a mnemonic that may help all medics do better refusals, both the refusal where the person is refusing against your medical advice and the standard refusal where people don't necessarily need to go to the emergency room, but you need to do what you can to kind of cover your liability. So after that call, I started doing some research, and then I later met Sam, who was an attorney with Grady, and we came up with a mnemonic that will help the medic, even new medics, old medics, help them get through refusals, even both refusals where the patient completely refuses care against your medical advice, and also your day-to-day standard refusals on motor vehicle crashes, minor slips and falls, and just giving you some tools to help you both guide you through that process and also protect you from liability. So we came up with CURED, C-U-R-E-D. That stands for capacity, understanding, the risks associated with the refusal, education, educating your patient on what the best choice might be for them, and then finally the decision, how they make their decision, and then the documentation of that decision is the second D.
So in looking at capacity, there's generally 4 things that a patient has to be able to show that they have capacity. The first being understanding of their situation, the second being an appreciation for what they're being told, their reasoning, and the expression of a consistent choice. And I'm going to let Nick talk a little bit more about the clinical assessment of the understanding and of the risks, but a patient has to be able to show not only that they're taking in the clinical information that you're giving them, but also that they can apply it to their own situation, that they understand what you're telling them in the context of their life and reality. They have to be able to show an expression of a consistent choice. They have to be able to tell you repeatedly, this is what I want to do. And so I'm going to let Nick talk a little bit more about the clinical assessment of it because, as I said before, capacity is inherently clinical assessment.
Really, the first part of determining if somebody has capacity to make a decision is to make sure first they have the legal ability to do so. Sam, can you kind of discuss what those things are in the state of Georgia?
So for a patient to be able to refuse, they have to be at least 18 years of age or an emancipated minor, which means that they actually show you some court documents showing that they've been emancipated. Minor children can make decisions for their own minor children, and pregnant women can make decisions for things related to their pregnancy or to their fetus, but not necessarily for other things. So the sort of classic situation is the 15-year-old pregnant woman who is in a car accident. She has a broken femur and doesn't want to go to the hospital because she doesn't want her parents to know that she's pregnant.
Yeah.
She can, of course, consent to things related to the assessment of what's going on with her pregnancy, but for that broken leg, the parents have to consent to that.
Right.
So in those tricky situations, we'll talk about this a little bit later, but make sure that you have your medical control number handy.
Absolutely. So now we have determined that the patient is legally capable to make a transport decision. Now we got to make sure they're mentally capable to make that same transport decision. And what I've heard a lot of medics say in the past is like, well, they were A&O times 4, so they were able to make a decision. Well, my 12-year-old is A&O times 4 all the time, but he can't make a medical decision for himself or doesn't have the ability to kind of understand that to be able to make a proper medical decision for himself. So we always tell people that get a little bit further down into capacity. Make sure somebody is actually capable of making a medical decision on their own. And that goes a little bit deeper than A&O times 4. A&O times 4 is great and it gets you a good start, but it doesn't get you all the way across the finish line. Some of the things we want to make sure is that our patients are able to have both short and long-term memory. So you've probably already asked some questions like, what was the last thing you had to eat? Well, that's good for establishing short-term memory. And you may have even asked them some questions like, when was your date of birth? And that's good for establishing a long-term memory. But you might want to ask them, what was something significant that you did last weekend, just to make sure that they have good understanding of, and can demonstrate that they have both short and long-term understanding. You might also want to check for basic language and math understanding. You can ask them questions like, starting at 100, count backwards by sevens, like 100, 93. Now I'm not showing capacity. But you keep going and see if they can at least talk about those numbers. Or can you say a sentence? Can you remember some things for me? You might say, hey, I want to say pig, quarter, blue, and Chicago. Start talking about something else, continue your assessment, and come back a minute later and say, hey, can you repeat back those 4 words that I told you earlier to remember? You can also ask quick questions, and then always ask family members if they're available and bystanders, and say, hey, is this the normal level of awareness for this patient? And just kind of get a baseline with that. And then finally, rule out any medical causes of any cognitive issues. And those, your hypoglycemia, your hypoxia. Rule out anything that could be causing them to have any cognitive or capacity decisions. But go deeper than your A&O times 4 to be able to protect yourself, to say, I evaluated this patient and they were able to show me full capacity, or get enough clues to be able to call medical control to say, hey, this patient doesn't seem to have capacity and we would like to take them to the hospital. Next is understanding. Make sure in very simple terms that your patient understands exactly what's going on. With that patient, a 70-year-old male, I was a brand new medic. I remember saying things like myocardial infarction. Well, he didn't understand those terms. He didn't know what I was talking about. It was easier for me to say, sir, you're experiencing chest pain right now. I have hooked you to a cardiac monitor, which is showing me that things might be going wrong in your heart that I can't fix here. I think you might be having a heart attack and we need to take you to the hospital where they can fix your heart attack without any resulting or continuing damage. So use simple terms and then try to ask them to repeat back to you in their own words what you just said, to make sure or to document that they have an understanding of what you've told them and what you advised them of what's going on. Next, make sure you explain all the risks of them refusing patient care. In this case, the gentleman was probably having an MI, he was probably having a heart attack. I need to explain to him that he could eventually pass out and possibly die. And again, use the most basic terms you can use to explain what's going on. And no matter what the situation, you as the medic can vary that based on the situation. Motor vehicle accident. You can say, hey, you've been in a motor vehicle accident. You're telling me that you don't have any pain, but you may have injuries that we cannot see and we cannot rule out here without taking you to the hospital. So make sure you describe the potential risks of refusing treatment. Also, explain the benefits of emergency care. Like we did with the 70-year-old male having chest pain, we said, if we get you to the hospital now, you can get into the cath lab, which I know is kind of a technical term, but you can be seen by the doctor, and that doctor can reverse the effects of that heart attack within the hour, completely allowing you to return or resume to a normal life. So make sure they understand the benefits of emergency care along with the risks. And then makes them verbalize their understanding of both their risks and benefits, and ask them to repeat back to you again in their own words what could happen if they didn't go to the hospital by ambulance. Finally, it's your responsibility as a medic to educate your patients on any alternative options. Maybe there's an urgent care down the street. A lot of us experience areas where not all hospitals are built the same. If the patient continues to refuse, they may say something to the effect of, I'll just go see my doctor tomorrow, or I'll go down to the urgent care down the street, or I'm going to go to my closest rural hospital that might not be the most appropriate location to fix their problem. Make sure you educate your patients on that. Tell them that your patient care provider or your private care provider might not be able to handle this complaint, or the urgent care down the street doesn't have the ability to x-ray a limb, or that the hospital that you want to go to is not the most appropriate hospital for you to attend. In the example of the 70-year-old male, maybe the closest hospital was the most appropriate facility that has a cath lab and everything they need to treat that patient, but maybe it's not. And having those conversations and taking those moments to educate your patients is extraordinarily important. And also, before you leave, remind the patient, and we're not there yet, we're not quite to the point where you're allowing them to sign that piece of paper and walk out the door, but remind them before you leave, hey, feel free to call us back. If something changes or if you change your mind, you always have the option to call 911 and we'll come right back up here, and make sure they're aware of that.
And that's interesting that you brought that up about you're not at the point to sign the form, because everybody says, well, I have the form signed. They signed the refusal, so that absolves me from all the liability. No, it doesn't. That refusal form is worth the paper it's written on, and that's it. If it doesn't include, if your documentation does not include all of these other assessments that you've done, then you've left yourself open to liability, because it's hard to say whether the person truly understood what they were refusing when they signed the form. And unfortunately, it is a fact that a lot of folks will just put the refusal form in front of the patient and, hope to get off the call as soon as possible.
And that is not your get out of jail card at all. That documentation form is not really your patient care report. Is going to be what makes or breaks you when you go to court, possibly 2 years later.
And that's the most important thing to remember. Most lawsuits don't happen until 2 years after the fact. And most people don't remember what they were doing 2 years ago today. Your chart is the roadmap for the things that you did and the things that you assessed on your patient and the decisions that you made, because it's not the really weird call that you always remember that's going to end up in the lawsuit. It's going to be something that's kind of a run-of-the-mill case. And if you haven't prepared your documentation properly, then you've left yourself open to claims.
One of the best ways to make sure that you have good, adequate documentation is use that mnemonic. Use that CURED mnemonic to help you write your narrative. Put in there capacity, or C. I judged the patient's capacity. They were alert and oriented to time and place. They could tell me, what happened yesterday. They could tell me what happened today. Their family and bystanders said they appeared normal for their normal baseline. Add those, then go down to you. I explained to the patient what their problem was. Use the terms that you used. Write in your narrative that the patient replied back to me that they knew they were having a heart attack, and use their language or their statements in quotation marks. This is what the patient said. Continue down the risks. I explained the risks associated with refusing care and transport to the hospital, And those risks were, heart potential death, whatever you want to put in there, whatever you explain the risks to be, put those under that R category to show that you explained your risks. E, I educated the patient on other destination choices. I told them, and I definitely put this in your narrative as well, it is always a big help. I instructed them that if anything changed or if they needed additional help, they could always call 911 again. And then D, for that decision, the patient stated that they did not want to go to the hospital and that they signed your refusal form. Finally, don't forget you're not alone, especially in situations like this, where if your medic spidey sense is going off and you believe this patient really needs to be seen, don't be afraid to call your medical director, medical control. I've been known to call patients' private physicians before and hand that phone from the patient's physician to the patient and have that doctor have a conversation with the patient. Maybe he has a better relationship with his physician. And family also works really well as well. In this particular case, I'm going to kind of tell you how it ended. We called the patient's granddaughter. And the patient's granddaughter, who I believe was younger at the time, said, please, Granddad, please go to the hospital. And that's kind of how we resolved that. It was hearing that voice from one of his loved ones that convinced him to go seek and get treatment. So always remember to phone a friend. Don't feel like you're out there on your own.
A new sort of popular topic is whether or not EMS providers themselves can make decisions about where a patient should be transported or if they need to be transported at all. And there has been some push for more paramedic-initiated refusals. And honestly, the jury's still out on it as to whether or not it's okay for a paramedic to tell a patient that they don't need to go to the hospital. You want to be careful about that. There are some circumstances where you might be able to recommend alternate treatment destinations, but definitely be extra careful about pushing your patients toward a refusal. There's a new transport model, of course, for ambulance companies to try and move patients to alternate destinations because we know not everybody does need to go to the ER. Sometimes it's okay to take them to the urgent care or to set them up with an appointment with their primary care doc the next day. Insurance companies, Medicare, they are moving toward this payment model, and it remains to be seen how that's going to affect patient refusals. Now, of course, the problem comes when these cases result in lawsuits. This particular case involved a 2-year-old girl named Stephanie Stevens in New York, whose mother called the medics during a really bad snowstorm because her child seemed to have some croup symptoms, was concerning for shortness of breath and other things. And basically, when the crew arrived, they told the mom, we're not taking her to the hospital because the snowstorm is really bad. They did not do a proper assessment on her. They did not document the things that they did. And ultimately, when the second crew showed up on another 911 call and took the patient to the hospital, she was found to have some pretty severe pneumonia, and she actually died from it. So that lawsuit came about, and among the allegations contained was that the paramedics failed to document the refusal at all. And they certainly didn't document their assessment.
If I remember correctly, this PCR basically said no patient found or no incident found, something like that.
Yes.
Yeah.
Be extra careful with those. In another case out of Florida, another sort of failure to assess case, I think we can call it, a woman named Miss Galloway had actually had a C-section a few days prior to the EMS call, and then she was found by her mother passed out in the bathroom. This was in a not really nice neighborhood in Florida, and the crew that showed up assumed that she had had a drug overdose and treated her accordingly and not well. They failed to do any kind of assessment or assess her vitals. They didn't tell her mother where she could take her, which hospital she could go to, and it turned out that Miss Galloway had a stroke. And $2.75 million later, Hillsborough County had to settle that case due to the lack of assessment and the fact that they didn't properly handle the refusal.
So let's look at a couple of narratives, and these are real narratives that we pulled out of different, we won't say whose, record management systems. We might have cut some down a little bit for clarity, but we're going to read a couple of those and just kind of go over the documentation aspect of doing a patient refusal and kind of talk about what's a good documentation, what could use some work. So I'm going to start with the first one. Dispatch to residence for female with complaint of difficulty breathing. Upon arrival, found patient A&O times 4. Remember we talked about that A&O times 4 earlier today. And the patient states she is fine and does not want to go to the hospital. She feels better after the use of a rescue inhaler. Patient agreed to let us check vitals, all within normal ranges. Patient released to care of herself and husband with instructions to call 911 if symptoms return. All right, there's a lot of good things on here, but there's a lot of things we kind of like to pick apart as well.
So remember we said that most lawsuits happen 2 years after the fact, and your documentation is going to be what reminds you of the call. So the best documentation includes a couple of things. One, your description of the scene and your patient presentation. What did you get called out there for? And did you find what you expected to find when you got there? 2, what kind of interventions did you do, and why did you choose to do them? What sorts of treatments did you consider? What sorts of alternative diagnosis did you consider? And have you documented your decision making? And then finally, describing the scene, the patient's evolution, and the scene's evolution. You know, ended in a refusal, ended in a transport. So one of the good things out here is, dispatch to residence for a female with complaints of difficulty breathing. Upon arrival, they found a patient with some difficulty breathing who felt better after the use of her rescue inhaler. So the scene looks like what they expected to find.
Yeah, and a lot of things they're doing here is they're breaking it down. I would say you didn't really establish capacity here. You did say she was learning oriented times 4, but you didn't go a little bit further into that establishing capacity. We kind of put in here that there is some understanding. The patient stated she felt better, which is good. We go down to risks. We didn't really have anywhere here where we explained risks. Hey, you might be having an asthma attack. If your rescue inhaler ran out or something to that extent, you might need additional assistance. There's not really an education statement on here. There is a decision. The patient felt better and she decided not to go. And one of the things I do love about this particular narrative is that conclusion is that the patient was released and left with her husband with instructions to call 911 and symptoms return. So I would say that's really well done. The next one, unit responded to an MVC and the patient refused treatment. All signatures were obtained and unit is back in service without incident. And one of the things I hate to say is this is a very common narrative on most MVCs. And right smack dab in the middle it says signatures were obtained, because at that point they're under the impression that they're going to be off scot-free, they're free of liability, we got everything signed, we're good. Right, Sam?
One of the interesting things about this chart is you can see they completed the demographics, but no vital signs, no chief complaint, no discussion of past medical history or medications, no assessment was done other than to say he responded to an MVC and the patient refused. We don't know what the patient looked like, what the presentation was. We have no idea if this was a car wrapped around a tree or if it was a 3-car insurance seminar on the side of 75. We don't really know what the scene looked like. And there will be so many of these calls that this particular crew will run, and should this one result in a lawsuit, this doesn't help them remember what they did and what was happening on the scene.
Absolutely. Like you were saying, 2 years later, if an attorney hands this to you and says, tell me what you did on this scene, as a medic, I don't think I could do it. This one, EMS dispatched to an unknown age female with AMS, requested by Sheriff's Office. That's altered mental status. EMS responded and arrived on scene to find an elderly white female with a purple fleece blanket wrapped around her shoulders. Subject has an open airway and warm, dry skin. As soon as EMS personnel approached subject, she immediately became defensive and said she did not request EMS, nor did she want us. EMT asked Let's see. EMT asked patient various questions to confirm that subject was in her right state of mind, and all questions were answered correctly. Subject did seem to ramble and not make any sense. All right, hold on. This is confusing. When asking subject if we could check her vitals, she refused and refused to even give us her name. EMS unit back in service. All right, what do you think?
This is one of my favorite charts because it's very detailed. Unfortunately,
Down to the color of the blanket.
right, but unfortunately those details don't really tell us the kind of things that we need to understand. Some assessment was clearly done. Subject has an open airway, warm, dry skin, so they were assessing her speech patterns, they were discussing her breathing, they were discussing her circulation, and there were some questions that they asked, but she rambled and didn't make any sense. And this is an altered mental status call. So the crew did not go into more of what they were asking her and the kind of things she was answering. And what it sounds like is this is a patient who really didn't have capacity. She was altered, she didn't understand what was going on, and just because a patient refuses to give you the name or refuses to let you check vitals, there is some assessment that you can do, and this person seems to meet the definition of a patient, so depending on your local protocols, of course. But I think they spent a lot of time describing the scene and clearly thought this documentation is going to save them from any problem because it's super detailed. But it's not the kind of details that help protect you in a refusal case.
Absolutely. One of the parts here is they actually seem to contradict themselves. Down here, they talk about they're actually going through that capacity assessment. They're asking her questions to see what her level of capacity is. But then, as soon as they say that, they say, but she seems to ramble, and what was the exact terminology? She was rambling and not making any sense. So they said she has capacity, and now they're saying she doesn't. So don't be contradicting yourself, especially with these weird refusals. We always like to depart with a couple of takeaways. And these are the 4 things that we really want you to remember and to focus on. First one, the patient was A&O times 4 is not enough. It could accurately describe the events leading up to a call, and demonstrating the ability to recall events in the past is a much better statement, or to start to demonstrate that the patient showed capacity. Next is the patient stated. Always use the quotations. I understand that I'm potentially having a heart attack and could die as a result of this condition, but I do not wish to be transported to the hospital. The patient's exact statement showing that they demonstrated understanding and they were making a decision to make a refusal. Sam, given that as a piece of evidence as a defense, does that help you a lot more than not?
Oh, absolutely. Anytime that you can write down what the patient is telling you about their understanding, that's very helpful, because somebody can't then come back and say, well, I didn't know what was going on with me, because their statement is right there that they did understand they were potentially having a heart attack or some other condition.
Yeah. Next, phone a friend. You're not out there alone. Use medical control. Use private physicians. Use family members. Call your supervisor. You're not out there alone, especially if you're on one of the refusals that just doesn't seem right and is making you nervous. Make sure you reach out to somebody else and get that consult. And then that last statement, always try to add in the bottom of your documentation, the patient was advised to call 911 if their conditions changed or they got worse. I can't tell you how important that is, that you convey that to the patient, and you also document that you did so. Sam, normally we give this presentation at conferences, and as soon as we get done, you get flooded with people coming from the audience asking you questions because you're the attorney, and you're probably one of the first EMS attorneys they've seen. So I know some of those questions that you get, just kind of seeing that go. And one of the things we talked about is how to define if somebody is able to sign a refusal. And in the state of Georgia, because that's where this training is going out, we already talked about they got to be over the age 18, and there's very rare exceptions like emancipation and then pregnancy or having a child. They can make decisions for their fetus or their child, but then they can't make decisions for themselves. So the question always comes up, what happens then? So I want to give you a scenario so we can kind of go from there. You got a 17-year-old and a 16-year-old in the vehicle. Or I'm going to make it harder. A 17-year-old and a 15-year-old in a vehicle. The 17-year-old is babysitting the 15-year-old, or they're driving home from school or whatever. They get in a wreck. No major injuries, cuts, scrapes, and bruises, and that type of stuff. What do we do?
Since both of them are under 18, the parents have to be contacted, or the guardians have to be contacted. This is always a difficult situation because sometimes people don't want to give up the information for their parents. And in cases like that, you may need to reach out to your supervisors, you may need to reach out to the local police, and you may need to call DFACS. So those are difficult situations to work with. Make sure you are always phoning a friend in those situations.
Right.
Now, my other favorite one is the kids who are involved in a school bus wreck.
Yes.
But the teacher is on board with the students.
Okay.
And can the teacher either consent for the transport of the children to the hospital, or can they refuse the treatment? And usually what happens, of course, when you have kids going on a field trip is somebody has signed a waiver form that allows their chaperones to make decisions for them. The hope would be that you could talk everybody into going to the hospital for an evaluation at that point, or that you could get the parents' numbers for the various minors and just call them yourselves. You may have to spend a little more time on that scene.
I'm going to shift to the other side of the spectrum because this is something I hear of a misnomer a little bit. Let's say the child is experiencing an emergency, major bleeding or clearly injured in an accident, and there's nobody there to serve as a parent to consent for treatment. Kind of talk about that.
So there are some situations where you can act under what's called implied consent, which means that if the person was able to consent, they would want to go for treatment. Sort of classic one is the unconscious gunshot victim.
Right.
You don't wait around to see if they wake up. You just take them to the hospital to get them fixed. Same for a minor child who may be experiencing a significant medical emergency. Always better to err on the side of transporting. And the one thing to remember is that these things are guidelines. They're not necessarily going to prevent you from being sued. But if you've tried to do your best and do the right thing for your patient, that gives your services lawyer something to work with, and that's really what you want. You want people to say, well, they tried to do their best.
Right.
They tried to do what was right for the patient. So always be acting in your patient's best interests, and if you have questions about it, always reach out to your medical direction.
Yep. Last one I got for you, and then we're going to close it up. But a term we hear sometimes, or some of us have heard, is the term in loco parentis. And in Georgia, at least, that allows pretty much any responsible adult to take responsibility for a child if the parent can't be contacted. And nowadays, with cell phones and technology, it's very rare. But in the instance of a child at a school playing in the jungle gym, falls off, one of the tools, maybe the level of injury, it might be questioned, can't get a hold of the parents. Can the teachers and the principal act in loco parentis and make decisions for that child?
Yes, for somebody who has sort of custody and control of the minor at that time, so school administrators, teachers, oftentimes the school nurse, they can consent for you to treat the patient. Probably, again, should be extra careful if you're taking a refusal from that person.
And then I would say also it's probably very important, either a refusal or a transport, you document, hey, attempted to contact parents numerous times, make sure you write that down at this number, at this time. That would probably be something that would help you as well.
Yes, absolutely.
All right, that's all I got for you. That's all the questions today. If you do have any other question about documentation or any of the medical legal topics that we speak on, for either me or Sam, you can always reach us at the information provided here on the screen.